what I'm going to try and talk about is give you a very broad overview, which is really about empowerment. Okay? You are probably unwillingly the consumers of cancer care, but that's the situation you're in. How do you turn that to your advantage? How do you empower yourself? And a lot of that is about recognizing that one size is not going to fit all, and it's about personalizing that cancer experience. And I'm going to talk about it in three things. So one is there's going to be some science, so you're going to be much better educated in about 10 minutes' time, about how all of the move in cancer care is about personalized medicine, about tailoring an individual treatment plan to you. I'm also going to talk about how you personally have to deal with all of the information you're going to be exposed to, or if you're a carer, all of the information your loved one is exposed to, from the internet, from the TV, from friends, from relatives. If you like, sometimes unsolicited second opinions, and then sometimes you may go out and seek a second opinion, and I'm going to give you some advice in terms of how you deal with that. And finally, I'm going to give you some do's and don'ts of cancer care, and in particular, I'm going to give you some examples of how individuals have found a way when the bombshell of a cancer diagnosis goes off in their life, that they refocus and they find a way of moving forward despite that, or sometimes even because of that cancer diagnosis. But because we're going to be dealing with big issues, big ideas, I'm going to start you off with a really profound question that I want you to ponder during this talk, a question that has puzzled mankind for many years. And at the end, I'm going to try and give you an answer. And that question is, when is the best time to eat a cupcake? Now, for Dr. Purcell, the answer would be never. But for the rest of us, there is an answer to this. OK, so it's Saturday morning. What better time to jump into cancer molecular biology? So let's start. What is cancer? Well, cancer is a genetic disease. And what I mean by that is inside every cell in your body, there is the instruction manual for building you. That is the DNA. And what happens is in some of the cells in your body, those instructions go wrong. They get mutated. Where do those mutations come from? Well, sometimes you inherit them, but usually you don't. Occasionally, what you might inherit is a predisposition to get mutations, but you usually don't inherit the fundamental mutation that gives you cancer. Most other mutations we acquire as we go along. If you think about when most cancers happen, they happen as we get older because they're things that we accumulate during our lifetime. They come from things that we can recognize, smoking, ultraviolet light, radon gas, and things that we don't know, the unquantifiable risks that we go through every day. And finally, even if you lived a blame-free, perfect life, you would still get mutations. Every time one of your cells goes from 1 cell to 2 cells to 4 cells, it has to take all of that complex DNA information and replicate it. And it doesn't do it perfectly. So it will generate mutations whatever you do. Now, a lot of people did some studies because you can actually calculate the number of mutations that occur. Sometimes you can actually measure them. And the surprising thing, which is probably you're the wrong audience to tell this to, but the surprising thing is that we don't get cancer more often. With all of the mutations that exist, why aren't we all succumbing with cancer when we're 5 years old? And the answer is we're actually quite good at repairing that damage. We have proofreading mechanisms in our cells that will say, hold on, there's a mutation here. It will stop the cell from turning over. It will repair the damage, and then the work can go back on and the cell can start to turn over. So actually if the damage is too much, what you'll actually do is not, instead of turning the cell over, if you can't repair that damage, you'll actually delete the cell. The cell will commit suicide. So one of the things, in order to develop a cancer in the first place, is you almost have to knock out those proofreading, those repair mechanisms. And that's one of the first things that happens. And then later, when you get the mutation that actually causes your cancer, it stays there because the repair mechanisms have gone. Now, the knock-on effect that the first event that you have to have is to interfere with your repair mechanisms is your cancer is now genetically unstable. Those particular cells in your body now have impaired proofreading, and so every time the cancer cells go from 2 cells to 4 cells to 8 cells, they generate more and more and more mutations, and you get diversity within your cancer. We sometimes think of cancer as this solid, evil blob that's attacking us, but it's actually a population of cells, each of which is slightly different. That diversity then acts as the palette on which evolution takes place. If you remember Darwin's theory of evolution, there's diversity in the finches on the Galapagos Islands, and they adapt, they're selected out each generation to be the best fit for that particular environment on that particular island. And the same thing happens with the cancer. Unfortunately, the environment is us. So over time, all those different mutations select out a particular spectrum of mutations that give the cancer abilities that give it an advantage in the environment of us. And that might mean avoiding your immune system, it might mean growing its own blood supply, it might mean having the ability to spread to other parts of your body, being resistant to some treatment, etc. Okay, that's cancer. How do we treat it? Well, there it is. You can see it's moving along. It's developing more mutations. More color is going on as the cancer grows because it's genetically unstable. When it's just one lump, so that might be called an early stage disease, you can get rid of it completely sometimes. You can cut it out, or if surgery is not feasible for whatever reason or because you choose not to, you can sometimes destroy that area with focused radiation treatment, what's called radiotherapy. When the cancer has spread more distantly, so it's developed more of those mutations and now it's gone to your liver, your bones or brain or wherever, now it's not impossible to do surgery or radiation, but it's much rarer. Partly because there's a lot more of an effect on you if you're cutting lots of bits of you out, partly because the concept that you're leaving stuff behind on a microscopic level makes people less inclined to do it. So when your cancer is in lots of different places, we tend to give a treatment that goes to lots of different places, and that essentially means drug-based treatments in all their various forms. And there's a halfway house, so if you have surgery, sometimes you worry there may be microscopic disease left behind, a seed lurking somewhere else, and so sometimes you'll go through a short course of drug-based treatment as an adjunct to the surgery, what's called adjuvant therapy, in order to increase the chances of you being cured just from the surgery alone. Now, what is the principle behind anti-cancer treatment? So I'm going to give you an analogy. So before we were on this fancy campus, most of the healthcare in the University of Colorado, including cancer care, was down at the 9th and Colorado campus. And that ugly-looking bridge is still being preserved. I don't presume it was the best thing they could think to preserve, but it is quite fantastically ugly. And I got up early on August 29th, and this is what happened. On the left-hand side, they cleared Colorado Boulevard, and then it went boom, 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 and they collapsed the building. And everybody cheered. It was actually kind of fun to watch. And this is what it looked like the next day. Okay? So this is the analogy for cancer treatment. Why? Because it's effective and selective. That means the cancer, the building has been collapsed, but the building right next to it didn't even break the windows. So whether you're talking about surgery or radiation or drug-based treatment, you need to find a way of killing the cancer, but not killing you. We can all incinerate cancer, but that would incinerate us too, so that's not the solution. So the way we've traditionally done it has been with chemotherapy. Now, chemotherapy, most people have the idea that there's lots of side effects with it, and that's not untrue, but there are many different chemotherapies. But this is a general principle in terms of understanding how the chemotherapy works. The chemotherapy, if you look at the gray box down in the bottom right-hand corner, goes in and damages that same DNA which is causing, that has the mutations in it. And what it's doing is it's kind of like maxing out all those checkpoint mechanisms. So the damage is detected. Sometimes in the healthy cells, the cell may pause, repair the damage. But remember, the cancer cells have impaired that damage cleanup. So they keep all that damage around that you've damaged from the chemotherapy. Then when the cell tries to divide, and remember cancer cells tend to divide relatively quickly, they run into the checkpoints with all of this baggage of damage, and that causes the cell to die. And if you look in the graph, what happens is by giving it intermittently, you allow the good bits of you to be damaged and repaired, whereas the bad bits, the cancer, get damaged. They don't really repair it very well. You come in with the chemotherapy again, they get more damaged, and you get a widening gap. And that's how you get the selective and effective effect of chemotherapy. So as we've said, the fact that the cancer tends not to repair the damage and tends to drive through these checkpoints rather quickly, that's what allows this selectivity to occur. About 10 years ago, a new class of drugs came about, and they were what you might call designer drugs, or targeted therapy. They were more often tablets than intravenous, and they were more often given every day than intermittently. The term targeted therapy is sometimes misunderstood. It does mean that at least one target of that drug is known. This is a something-something inhibitor. It doesn't mean that's the only target of the drug. Many of these drugs are not really like a key in a lock. They're more like a kind of skeleton key. They can unlock several locks. It doesn't mean that there won't be side effects. That target may be present in some of your normal tissues and be important to your normal tissues. Some of those off-target effects may also be present in normal tissues. It doesn't mean that the target is necessarily important in your cancer. You have to prove that. Just because you have a key and a lock, it doesn't mean that lock is present in your cancer. And finally, perhaps most confusingly, it doesn't mean the drug only goes to the tumor. It's not targeted literally to the tumor. It goes to every cell. The target is differentially important in the cancer than your normal cells. I'm going to give you an example. It's a lung cancer example. Why lung cancer? Well, lung cancer is a very common disease. It's also what I'm supposed to know about. But the principles apply to almost every other cancer. So the most common type of lung cancer is called non-small cell lung cancer, and 90% of it, if you look down the microscope, expresses a protein called the epidermal growth factor receptor, or EGFR. And that's the brown stain in this picture here on a section of a cancer. And so probably 15 years ago, people thought, well, if it's expressed in the cancer, maybe it's important. Why is it commonly there? So they made drugs to interfere with it. So these things, these are growth factor receptors. They sit on the surface of the cell. The two parallel lines are supposed to be the surface of a cancer cell. The blocks inside are what happens when that's active. It sends those zigzag lines, that's signaling inside the cancer cell, telling it to grow and divide and spread and do all the things that cancer cells do. And you can shut that cancer molecule up from signaling by giving drugs that go into the cell and interfere with the signaling of that specific molecule. And in this example, they have names like erlotinib, gefitinib, and afatinib. Now, you remember I said just because they're a targeted molecule, they're not necessarily free from side effects. Remember, it's the epidermal growth factor receptor. So where do you think it's normally expressed? In your skin. It's also expressed in your gut. So when you interfere with it, you get a rash and diarrhea. So just because it's a targeted therapy, it's not free from side effects. In terms of whether it works, this was a learning process. So this is 10 years ago. This is a study that was done by the Canadians. They took patients with advanced non-small cell lung cancer, and they gave them either a placebo tablet or they gave them one of these EGFR inhibitors. And although the drug got a license in 2004 because it prolonged the time that people with advanced cancer stayed alive by a couple of months, this is the graph of how long it took for their cancer to grow, what's called the progression-free survival. And it's time on what's called the x-axis down here, and on the y-axis, it's the number of patients. And each step down is a patient's cancer starting to grow. If you took placebo, it took 1.8 months before your cancer started to grow. And if you took the tablet, it took 2.2 months. And if you're impressed by that, I'm not. That's less than 2 weeks. I mean, that is really pathetic. And it didn't get a license on the basis of that, it got a license on the basis of survival. But this is telling you this is not a drug that is particularly effective when you give it to everybody. So just because 90% of people express that protein, clearly it wasn't important in 90% of people. Yet we always knew that there were some people that we gave that drug to and something miraculous would happen. So this is actually one of my patients. She had HIV. She had all of these fluffy infiltrates in her lungs. That's the white stuff that you can see around here. This is a CT scan of her chest. And she got worked up for every infection under the book because she had HIV. Eventually, they took a little biopsy. That's what that is. And they said, oh, my goodness, she's got lung cancer. And she was very, very unwell. And the infectious diseases doctors, this is what goes on in hospitals, were delighted to pass her on to the oncologist because they didn't know what to do with her. At this point in time, she was on oxygen, she was in a wheelchair, she had lost something like 40 pounds in weight. And at that point in time, that drug that I just showed you, that tablet, erlotinib, had got licensed. It was marginal benefit, but it didn't have that much in the way of side effects. She wasn't fit for chemotherapy. She was barely fit enough for a haircut. We gave her the erlotinib, and she literally rose from the dead. She came off the oxygen. She went back to work. She actually put on nearly all of the 40 pounds in weight and quite a lot more. As you can see here, we had to have dietary advice at some point. And she did great. So there were always those exceptions that were exquisitely sensitive to the drug. And it took maybe 5 years to try and figure out who that group of people who were getting all of the benefit were. And it turned out that only about 10% of people with lung cancer have not just the expression of the protein, but inside the cell a specific mutation which leaves that protein stuck in the on position, which you can't tell just by looking at the expression of the protein. And when you take those people proven to have an EGFR mutation, and give them the same drug at the same dose, this curve shows you that the median time for their cancer to grow isn't 1 or 2 months, it's 14 months. And that's a median. That means 50% of people are doing better than that. So suddenly, the idea that one size wasn't going to fit all and we were going to personalize therapy came home to roost. The idea that you would do some kind of test on a person's cancer, what's called a predictive biomarker, and say, you need this treatment, you don't need that treatment. Now, that has taken off in many different places. Indeed, there are many commercial companies that will now do extensive sequencing of your cancer. Foundation Medicine is one, Caris is another. And they will send you back this kind of information. So these are all of the mutations in your cancer. And you might think, I've hit the jackpot. I have all of these things. I can spend all day Googling these and figuring out what's driving my cancer. Here's the problem. The more mutations you have, the more likely there is a committee driving your cancer than one single dictator. So the chances that you will be able to just give one treatment and turn that cancer off go down. One of the problems is when you send it off commercially, they send you a little kind of Reader's Digest of what all of that means, and they have a very low bar for giving recommendations. So these mutations in this person's cancer, this was a cancer that was on somebody's skin, and these mutations, they said, well, there are these drugs sitting in the pharmacy for other reasons, what's called off-label use, maybe you could try those. And if you look at our special section on clinical trials, you can see there's a whole bunch of clinical trials that might allow you in if you have these mutations, et cetera. And so you might get very excited and go to your doctor and you say, you have to prescribe all of these drugs to me now. And if you don't, you're a bad doctor. Or, I'm going to take my money and I'm going to travel to wherever these trials are because this piece of paper tells me I should do that. Here's the problem. Most of these are completely unproven. Most of these are not true what's called driver abnormalities, i.e. if you knock it out, the car doesn't come to an end. Some people out there are prescribing these off-label. Some of them are combining these all together with no concept of what the recipe should be. It's not a pound cake. You can't just combine everything at 1 pound of every ingredient. People will end up in the intensive care unit. And their metric for saying you should travel for a clinical trial is often very low. If you do one of these things, you need to talk to an expert so that you are not chasing down inappropriate leads, and we'll try and help you. I used to give a talk at this meeting on clinical trials. It's now available as an insert in this book. So it's called, Who Are Clinical Trials For? Guinea Pigs, Test Pilots, or Prize Poodles? And that actually came from a patient of mine who said, I don't feel like a guinea pig in a clinical trial. With all these people fussing over me, I feel like a prize poodle. And you can find it. We'll get you these slides afterwards. This is a listing of all of the clinical trials going on in the USA. But this article is present in this handbook, which you can get on Amazon. You can also download it online. Okay, it's about lung cancer, but this is not about lung cancer. This is about all clinical trials. Okay, next section. Working well with Dr. Smith, Dr. Jones, and of course, Dr. Google, who's a very successful doctor. And this cartoon was given to me by one of my patients. I'm delighted. It says, I'm going to give you a mild sedative to counteract your really annoying questions. So where do you get second opinions from? Well, a lot of us get second opinions from non-doctors. That can be the TV, the internet, newsprint, friends, family, and chat rooms. Some chat rooms are incredibly powerful. This is Inspire. Inspire is dominated by lung cancer, but it actually has lots of different tumor type specific chat rooms. And some of the people there are unbelievably well educated. You get somebody who's a nuclear physicist and they get diagnosed with bowel cancer. And what happens? They become the world's smartest expert on bowel cancer because they're really smart people. And you can go on there and you can get everything from how do I deal with this annoying rash that's associated with the side effect of my drug, to who do you recommend for treatment for the deposits in my brain, to admittedly, my husband passed on this morning, I'm feeling really bad, can you give me some emotional support? Usually what I suggest to people is if you have just been diagnosed with cancer, don't go there straight away till you get your head around it. Often it is your carer, your friends and relatives, your loved ones who may want to go there first for you. Eventually, that becomes actually your support community and you become part of it. But it's a little scary when you jump in because there's lots of people further on the journey. When you get this advice, do bring it up with your doctor. But remember they're human. Remember they may be tired. Remember they may be emotionally fatigued from the 3 other patients they've seen. And try and do a little bit of homework first. So what kind of homework do I mean? Well, when you read that this treatment is working, find out at least if it's been tried in humans. Is it safe? Is it effective? Let me tell you that we have been curing cancer in mice for decades. That's why there's so many mice running around. Why? Well, here's a nice little thing. So we can grow little cancers in the back of mice, and they get better, they live a long time. Why? Because these are models. This is not a real cancer. This is one cell from a human cancer implanted in a mouse. It's very simple, doesn't have all that diversity. They're funny-looking mice, right? Mice in your garage don't look like this. They haven't got any hair because they've got an aberrant immune system in order to allow this completely artificial model to go on, to allow a human cancer to grow in a mouse. And for anyone who's trying to eradicate mice, mice are very tolerant, much more tolerant of toxicities and poisons than we are. So if you see something that has cured something in a mouse, that's great. But it doesn't mean it's ready to give to you. Other questions to try and find out. Did the news story relate to your kind of cancer? Was it bowel cancer and you've got breast cancer? Your stage of cancer, is this about early detection of cancer? Is it about reducing relapse? Is it about treating advanced disease? If you've got a specific type of cancer, let's say you have lung cancer, is it related to EGFR mutant lung cancer, ALK-rearranged lung cancer, KRAS mutant lung cancer? There's lots of molecular subtypes emerging. Is the treatment licensed? Now, if it is, it's very reasonable to say, hey, doc, why aren't you giving me this? This is clearly Pepsi-Cola versus Coca-Cola. I'd like Pepsi. Is it available off-label? That means it's sitting in the pharmacy licensed for some other disease. So let's say it's a licensed treatment for kidney cancer and you want to use it for bowel cancer. You can do it. A doctor can write a prescription off-label. We just accept the risks associated with that. The biggest issue is whether your insurance will cover it when it's used off-label. Is it available in clinical trials? That's the clinicaltrials.gov website you can look for. And often people come, particularly when there's a lot of information, they talk about compassionate access or named patient or an expanded access program. So I just want to give you 2 seconds to explain the difference between those. An expanded access program is a drug has completed all of its clinical trials, they have submitted that information to the Food and Drug Administration, but the FDA has not yet issued an opinion. So the trials are closed, you can't get access to the drug through trials, but you can't get access to it because it's not licensed, you're in the donut hole. Well, some drug companies, being optimistic that their drug is going to get licensed, create essentially a dumbed down clinical trial. A clinical trial is only a few pages, it's not that specific, you just essentially have to be able to walk through the door, they'll prescribe the drug, there's some very basic information that they'll capture. But it's still a clinical trial. They're not just handing you the drug. It's a way that legally they can give you a drug which is not yet licensed by having a minimally restrictive clinical trial. That's an expanded access program. Compassionate access is the same thing, but only in miniature. Essentially, it means your physician writes a minimalist clinical trial for one person, Mrs. Jones's clinical trial. Mrs. Jones will get this drug, we will check these blood tests, and we'll do a scan on this date. You can write it on 2 pages, but it still has to go through the same tedious regulatory process to be opened. Some centers are quicker than that than others. In an academic center here, it's still going to take usually a few months even to get a compassionate access. So sometimes we're not very good at that because that's the size of the donut hole. Let's say you do seek a second opinion. Your doctor is human, you got him on a bad day, you don't think they're listening to him. Doctors are human, this is the reality, okay? The same things that allow me to have a family that I care about, and all of those good emotions about being human make me susceptible to all the bad emotions about being human. I can be arrogant, I can be rude, I can be frustrated, I can be distracted, and your doctor can be like that. And so maybe you want to go get a second opinion. If you expect your doctor to be superhuman, you're going to be disappointed. Doctors have egos, so be sensitive. I realize that's a surprise to you. Specialists are more used to giving than receiving second opinions, generalists vice versa. So most community oncologists are quite happy for you to have a second opinion. If you've gone to MD Anderson first, they're going to feel a little weird if you then go to University of Michigan for your second opinion. They'll suck it up, but it'll just be a little weird. I think the best thing to do is engage your doctor in the process of finding that second opinion. Some people do it behind their doctor's back. They think they're going to upset them. I think most doctors are reasonable people, and if you sort of say, would you mind if I had a second opinion? They'd say, sure. They may even help you find a good one. And since the information you're going to get, ideally, you'd want to share with your first physician, they might as well know it's coming. I mean, imagine the tension you will create, the stress you will create in your life if you go get a second opinion and you don't tell your first doctor, and now you're stuck in the middle. So I think actually engaging your doctor in the second opinion is a good idea. Second opinion isn't always right. It's another human being giving it. And also, this isn't the military. It's not an order for the first MD to follow. It's an opinion. I have to be honest, if your doctor is too threatened by a second opinion, you should probably get one. Okay? People should be comfortable in their thoughts. One of the aspects they sometimes talk about the art of medicine is there more than one way of doing it. That's okay. As long as you can justify it, as long as you're consistent in your justification. And finally, don't get addicted to them. I have some patients who I'm their fifth opinion or sixth opinion, and it's okay, but I don't know, it's not the best pastime in the world, traveling around the country getting second opinions. Okay, the last section, do's and don'ts of cancer care. This is the, cancer care is a marathon. Sometimes you need to be the tortoise rather than the hare. And what I'm going to start with is some quotes from a friend of mine. So this is Jeff Oxnard. Jeff Oxnard is a medical oncologist at the Dana-Farber Cancer Institute in Boston. And he's very young, he's very dynamic. He shouts at people and points at them. He'd be a great motivational speaker. He'd get on very well with Dr. Purcell. And this is what he says to patients. He says, don't act sick. And what he means by that is, do whatever you want, but don't be sedentary. Don't live on the couch. He says, don't lose weight. Eat whatever you want as long as it's got calories. Now, you're going to get some dietary advice today, so they may tweak that advice a little bit. He says, don't be a tough guy. This usually relates to men more than women, I have to tell you. If the doctor says, take your painkillers, take your painkillers. It's not a sign of weakness. Treat your symptoms. Call your doctor. You don't have to tough everything out. That's one of the reasons why we're here. One of the reasons why when you first come into the system and we give you all of those cards of people and the nurse and the social worker is make use of them. He also says, plan ahead. He says three things. You need a will, you need a healthcare proxy, and you need a vacation. And the logic is, you shouldn't spend your whole life seeing doctors. And I'm going to edit Jeff's comments a little bit and add a few of my own. So when you're first diagnosed, you do need to pause for a moment. Now that can be, I walk around the block, I spend the time feeling sorry for myself, I burst into tears, and then I move on. You have to figure out a plan for your work. Do you tell your boss that you have cancer? Do you tell them, don't worry, I'll be back at work next week, or do you say, I'm going to take the next 6 months off? I don't know if I'm coming back. You have to decide what you're going to tell your family. I can assure you there is no convenient point in a conversation where the dinner time conversation lapses and somebody says, does anyone have cancer here? You have to force that conversation. You have to look at your finances. You have to look at your insurance, your healthcare insurance. I had a patient the other day who, despite having been diagnosed with cancer for 2 years, hadn't got Medicare Part D because he'd never had to be on an oral medication. So then when he got on a medication, he had this huge self-pay. It was like, well, he's a very smart guy, but what were you thinking for the first 2 years? You know, people need to go on medications. And a communication plan. That's about who do you tell, what do you tell. Do get informed. That's why you're all here. Empowered patients, informed patients, do better in every single sphere. Don't go crazy. That means you have to keep a sense of perspective. You still have to get up in the morning. You still have to go to the bathroom. You still have to buy groceries. You still have to write that birthday card for the relative that you didn't do last time. And you have to keep your sense of humor. Anyone who's been to my clinic will know there is a fair amount of giggling goes on in the clinic. And you may think, but you deal with lung cancer. It has an awful prognosis. Yet you can still find humor in every day. And that's what makes us human and what makes life enjoyable. And the last thing I want to end on is the concept of setting your sights on something, or to put it bluntly, about personal, not tumor growth. Because they've done studies in terms of the things that really make us happy. It's not money. What actually makes us happy is interacting with friends and family, having a sense of community, doing things for other people, and personal growth. That today I'm better in some aspect than yesterday. So there are some people with lung cancer sitting in the audience here, and they know that when you hit Dr. Google, you come across these kind of statistics, and they're like a slap in the face. These are the survival statistics that haven't changed for many years in lung cancer. This is advanced lung cancer, a cancer that you can't treat with surgery, and this is what happened when you just gave chemotherapy. And this is data from end of the 1990s. These are 4 different chemotherapy regimes, and this, to put it bluntly, is the chances of being alive. A year later is about 20 or 25%. So how do you live when you read that on the internet? How do you live focusing on the chance that you might be these people? And I'm going to give you some real-world examples. And every single person I'm going to give you has got advanced lung cancer, gave permission for their name and picture to be used. This is Johanna. Johanna lives in Arkansas. She was diagnosed with advanced lung cancer in November 2012. And she went through a series of treatments. Each one controlled a cancer between 4, some of the longer ones, 14 months. She came here to go on a clinical trial in March and had terrible side effects, awful side effects, lost an enormous amount of weight, had to give up her job, which she loved. And her sole goal, family was grown up, she would always come with her husband, her sole goal was, I just want to get back to work. And eventually we fixed the side effects, her cancer is responding, and she sent me this picture last week, and she's back. And she, as you can see, she works as a pediatric audiologist. And she loves her job. So there's a teenage kid in here listening to little beeps, trying to figure out if they're deaf or not. And she loves her job. So her goal is very realizable, I want to get back to work. Other people do it in a different way. This is Andy Hill. Andy Hill was diagnosed with advanced stage lung cancer in March 2009. Now, he had made a fair bit of money at Google. He'd retired early. And his wife said to him, you know, it would be a real shame if you died and the kids never saw you go out to work. And so he decided to run for public office. And he actually asked my advice the first time. He said, will I be alive to run for office? And I said, I think so. And he ran for state senator in Washington State, and he won. And in 2014, he was re-elected for his second term. The second time, he didn't ask my advice. He was on a mission. He just did it. And here's a quote from one of the newspapers. He said, the illness taught me not to sweat the small stuff. The person standing next to him is Janet Freeman Daly. Janet was an engineer at Boeing, also in Seattle. And she was diagnosed in May 2011, advanced stage lung cancer. She started a clinical trial, and then something changed in her. You remember I said that cancer, you can progress because you ignore the cancer, or you can progress because of the cancer. And she became this force of nature in terms of advocacy. And on that Inspire website I told you about, this is what one of her friends posted about in terms of just what she's done in 1 year. She was named the Longevity Hero. She attended this summit. She attended that summit. She presented at this meeting. She presented at that meeting. She attended the president's engagement something or other. She attended this. She was on a panel for the president's cancer workshop. She worked on some other panel. She did video. She authored articles. She runs social media campaigns. She did something with me. I can't even remember what it was. I mean, she's just like everywhere. And she just goes on and on and on. And her friend eventually went, "Good grief, woman." So she found new meaning by embracing her cancer. These are people who got married. Some of them are sitting in the audience. Matt, I actually went to his wedding. So this was his childhood sweetheart. They'd met in their first year in college. And he was diagnosed with lung cancer, as you can see, at a very young age. He's actually a medical student when he was diagnosed. And it was tough because he undoubtedly had some thoughts about, should I propose given the diagnosis? And we had a few man-to-man chats. And he proposed, and not surprisingly, she said yes. And it was just a fabulous wedding. Ben and Ellen are sitting in the audience. Ellen was divorced in 2003. Ben hung around. I'm sure they can tell you the story. And this is a great wedding photo. Michael, they'd been together forever. And the best thing was when he eventually proposed, I went, "What took you so long?" And then this is one of my favorite. This is Merritt. And he was diagnosed with lung cancer. And he proposed at the Buell Theater during a production of Taming of the Shrew. And apparently Jennifer said to him, she said, "I'm not going to be a shrew." That was her. So you can do that. Some people take even bigger decisions. This is Caroline. Caroline, advanced stage lung cancer, and they decided to adopt. A very brave decision. And she's doing great. And then this is a great picture that she sent. It looks like she's playing golf. But this is Grace's first East egg hunt, and they're doing great. And then you might say, okay, this is all fine for those people who, for whatever reason, are getting years out of their diagnosis. What if, let's not forget the reality that there's a lot of slope of that curve? Well, I want to give you another real-world example of people who can still find things useful in the short term. Mrs. Zeff was 84 when she was diagnosed, and she lived less than a year from her diagnosis. But she told me that what she really wanted to do was to be able to dance at her grandson's bar mitzvah. And that's exactly what she did. So this is my last slide. And how do you deal with a cancer diagnosis? And I'm going to seek inspiration from Christopher Reeve. Now, Christopher Reeve, as you know, was the actor who played Superman for nearly 10 years in the movies. And then in 1995, there was a horse riding accident, and he instantaneously became quadriplegic. Now, his wife, Dana Reeves, who, as some of you may know, was later diagnosed with lung cancer, stayed with him. And he wrote a book, which is called Still Me. And the reason behind the title is because when he first became quadriplegic, he became understandably depressed. You know, he was, even though he was still alive, he was grieving the loss of his hopes and the future that he had imagined. And he said to her, "You need to leave me. I will drag you down. You need to leave me, and you need to move on with your life." And she said, "No, you're still you." And that's what you have to hold on to with the cancer diagnosis. So, I said I'd give you the great question. The best time to eat a cupcake is before someone else does. Happy to answer any questions you may have.